Hi, I'm George Toit. I'm a pediatric allergist. I work at Guy's and St Thomas's and the Evelina Children's Hospital and in private practice at the Portland Hospital in London. I'm a pediatric allergy researcher and also a professor in clinical allergy. There's been a rise in the prevalence of food allergies in general, certainly over the last decade or two. And we know that throughout the world, milk protein, hen's egg, followed by peanut, sesame, cashew, depending on where you are in the world, are the commonest food allergies. You'd find, depending on the study, a range of between 2 to as high as 8–10% of young infants with allergy being allergic to cow's milk protein. Factors for food allergy are multifactorial. Most food allergy, the classic food allergy, IgE mediated, will develop in the first year or two of life. We know that the window of opportunity to intervene is often very early, at around 4, 5, 6, 7 months of age. For peanut allergy is when most of this will develop. And indeed for cow's milk allergy, you are not born cow's milk allergic. This develops early on in your first year of life after exposure. You will have to have seen the protein immunologically to make antibodies to it. And you can only see it through the environment or through your skin or through the breast milk or through your mouth if you fed a regular infant formula. The term cow's milk allergy is often applied loosely to adverse reactions to cow's milk. Cow's milk is obviously made up of many constituents and macronutrients, of which there is protein and carbohydrate. Being allergic to the allergy can give rise to immediate onset allergies. These are mediated by an IgE antibody, and that can very easily be measured for and would give rise to immediate onset symptoms, usually within 10 to 20, perhaps an hour. And the symptoms would be obvious. There'd be a dislike of the food, hives, swelling, vomiting, and this would come about each time the infant is exposed to this protein that they're allergic to. You can get delayed reactions to milk protein. These are more difficult to investigate, often would require elimination to see if the symptoms resolve, reintroduction to see if you can reproduce the symptoms. And there are classic syndromes within this umbrella. So cow's milk protein enterocolitis would give rise to fresh blood in the stool. And the infant would often be still thriving with this, would be otherwise happy, but the parents would notice this gelatinous, jelly-like, bright red blood in the stool. And this can happen even in breastfed babies where the mom is ingesting cow's milk protein. And with elimination of the cow's milk protein, the vast majority of these children would improve significantly. There are other delayed symptoms that can come on in response to cow's milk protein, such as the FPI syndrome, food protein-induced enterocolitis syndrome. In this syndrome, the infant would still ingest the milk, they would like the meal, but some hours later, usually 2 or 3 hours later, they would develop recurrent torrential vomiting. Often they can vomit 5, 6, 7 times in a row. The last vomits before the stops will be bilious vomiting, so there'll be green bile-stained vomitus. And the infant can often look severely ill at this stage, can be pale and floppy and grey and sweating, which is rare in young infants. This, of course, goes away over time. Thankfully, the infants come to no harm from this, although they're terribly ill when it happens. And it can take 2 or 3 exposures to cow's milk before the penny drops that the food is actually causing this syndrome, because it happens in a delayed fashion. Unlike immediate onset milk allergy, which is more obvious to the parents and to the healthcare givers. And then there are many other delayed symptoms that can come on where milk may be suspected. These would be a fractious baby, a baby that vomits with some reflux, a baby with eczema flares. And this is more difficult to measure and would again require milk avoidance and with an improvement in symptoms and then reintroduction at a later stage. And of course, if symptoms recur, then the penny drops that milk is related to these symptoms. It's not uncommon to have a mix of both delayed and immediate onset symptoms. So if you take the FPI syndrome, where you have the delayed vomiting, in a percentage, one study showed around 12% over time, this will revert to immediate onset IgE-mediated allergy. So sometimes these syndromes can merge, the delayed and the acute, or the acute and the delayed. For example, if you have IgE-mediated, immediate onset allergy, and you're exposed to milk and you have an acute severe reaction, it's typical for your eczema to flare for the next 5, 6, 7 days thereafter. So there's this very complex and detailed interaction between immediate and delayed symptoms. We know that other risk factors for the development of milk protein allergy and indeed other allergies are one existing allergy. So if you present with egg allergy, for example, the chance you'll develop a peanut allergy in many Northern Hemisphere countries is around 30%. It's extremely high. So when you diagnose a child with one IgE-mediated immediate onset allergy, always keep your mind open as to whether there may be an additional allergen, even an unrelated protein. CMA, cow's milk allergy, can be difficult to diagnose when the symptoms are delayed and variables. And so to prove causality between what you're eating and your symptoms in a condition that is often chronic, that waxes and wanes, is sometimes tricky. For immediate onset allergy, it's a very easy diagnosis, and parents will often come to me saying, my child is milk allergic. I'd ask them, how do you know? And they would say, well, I've exposed the child to this formula. They hate the formula. They develop hives, vomiting, they lock their jaw, they turn away, they're always hungry, they don't drink it with great avidity, they don't really like it. And so that's a very easy diagnosis to make. The other syndromes, such as FPIES, where the children react some hours after ingestion and they go floppy and grey and pale, can be difficult to diagnose, certainly after the first or second exposure. So it takes a while for that penny to drop. And the same with fresh blood in the stool. Unless you take a detailed dietary history, that can be a tricky diagnosis to make. It's important to make an accurate diagnosis of CMA. If cow's milk protein is playing a role in any of the child's symptoms, it obviously needs to be avoided. So if a mother is still nursing her child, breastfeeding, should need to be counseled as to how to supplement her diet with calcium and which alternatives to take, and when these could possibly be retrialed in her diet at a later stage and where this should occur. If the infant is exposed to milk and mom can avoid it and the symptoms improve, then that's a win-win situation, as breast milk is obviously best and should continue for as long as mom and infant are comfortable and thriving on this. If a modified, in other words, a hyperallergenic formula is required, then this is obviously expensive, it is sometimes distasteful, and so we don't like to apply these if the diagnosis is not accurate. But of course, if these formulas are required, then they will be recommended, and the children's symptoms will improve on this, which is important. So of the children who develop IgE-mediated allergy, far less than 1% would carry this into adulthood. So fortunately, it's a fairly rare condition in your teenage years and your adulthood. The vast majority of children with IgE-mediated allergy would have outgrown this by around 6 years of age. It's a bell-shaped curve. Some children achieve this far earlier, some take a little longer. But you can still outgrow milk allergy as you get older, and even in your second decade of life. We know through our studies regarding the dual allergen hypothesis that early high-dose exposure can stop food allergy in the majority of at-risk children with eczema, certainly to peanut. This is very effective at around over 80%. And we know that many governments, or one government, the US, and many other allergy societies throughout the world, including European, Australasian, African societies, are recommending early exposure to these food allergens, not avoiding for 1, 2, or 3 years of life like we used to do previously. So we're encouraging a broad and expansive diet. This is particularly important in young children with eczema. So the red flags for the development of food allergy are eczema. With a wide distribution, severe eczema, oozing, weeping, crusting eczema, eczema requiring steroid creams is a real worrying factor. And we know that the eczema can cause the food allergy, and the food can exacerbate the eczema if children are allergic to it. So I'd encourage healthcare practitioners to take early onset eczema very severely, to think about allergy, to take a detailed history. If they're worried about allergy, then of course they should refer on to somebody who can test for this or do the testing themselves if they're capable. And the testing, as we've discussed, would either be classic allergy testing if immediate onset symptoms are suspected, or avoidance and reintroduction if one or other food in mom's diet or in the infant diet, such as milk protein usually, is suspected as a trigger. Family history can be important, but it's not universal in young children with food allergy. So if we take identical twins, for example, with peanut allergy, only around 60% will be peanut allergic. So it is not absolute if the first child is food allergic that the next child will be as well.